Hi, I'm Dr. Andrew Kersten, orthopedic surgeon with EmergeOrtho in the Blue Ridge region, practicing in Asheville, Hendersonville, and surrounding Western North Carolina areas. Specialized in orthopedic sports medicine, specifically surgery in the shoulder, elbow, and knee. One common procedure we're doing as an orthopedic sports medicine specialist is reconstructing the ACL. And one of the long discussion points we have with patients is, what type of graft are we going to use for recreating the ACL? There are some times where we may be able to keep the patient's ACL and repair it, but more often we're having to do what's considered a reconstruction, which means we're making them a new ACL out of some sort of tissue. And that tissue can be either from their own knee, you can potentially use it from a different knee, and can be taken from a cadaver source, or what's considered an allograft. As orthopedic surgeons, we spend a lot of time discussing and arguing, if you will, at different meetings about the correct or most appropriate graft option. So I do like to spend a lot of time with my patients and their families discussing the graft options, because it really can affect your outcome long term. ACL reconstruction is a long recovery. It's a frustrating recovery for some, and it's going to take almost a year out of a lot of these athletes' lives while they recover. So if you're going to get this procedure done, you want it to work out successfully, you want to get back to sports and have as good of an outcome as possible. So there are very much differences in the different grafts and what you can expect. So the main categories of grafts would be what we consider an autograft, which means that's taken from the patient's own body. So often an autograft is either a section of the patient's quadriceps tendon, potentially what's considered a bone tendon bone graft, where we take a section of the kneecap, the middle part of the patellar tendon, and then part of the tibia bone, or one of the hamstring tendons. There are also what are called allografts. So an allograft is tissue obtained from a different source, and this is usually human tissue or cadaveric. So it has come from somebody that's donated that tissue, and that can be all sorts of different tendons from the bodies that have been either sutured or sewn into or the orientations we like to reconstruct the ACL. So there are pluses and minuses to both. With an autograft, we're using a patient's own tissue. There's usually a little bit better incorporation rate with that, and overall tolerance. The cost is going to be a little lower using the patient's own tissue than it would be taking or buying a cadaver graft, so to speak. There is, in theory, a risk of disease transmission anytime we take an allograft from a cadaver. Statistically, it's a 1 in 1.6 million risk of a disease. So these grafts are all tested for the diseases we don't want. So I reassure patients that it's very unlikely, but the risk is there. The allograft allows us to get a set size graft. So for some cases where we're worried about patient's anatomy and maybe not able to obtain the right size, we can basically open up a graft that's the right size and length and diameter. But the incorporation rate is a little slower with an allograft. So that can lend to a higher failure rate. And if we look in the outcomes data for the literature, there's a much higher failure rate in allograft tissues in our younger athletes. So I always advise patients under 25 to use an autograft or their own tissue. And as we get older in life, then the consideration for an allograft or the cadaver tissue is more reasonable. So there are three main autografts that we, as orthopedic sports medicine specialists, we use. Kind of the historical gold standard, most common grafts, what's called the BTB graft or patella bone tendon bone. In this graft, we're taking a little chunk of bone off the kneecap, the center portion of the patellar tendon, and then a little chunk of bone off the tibia. This allows bony incorporation at the tunnels, and then a kind of narrow ribbon-like strand of graft inside the knee. This offers good bone incorporation. It has good outcomes data. It's a strong graft, but the main downside of it is that it does often, about 30 to 40% of the time, create almost permanent anterior knee pain for patients, which can be real uncomfortable if they're doing a lot of kneeling or squatting. and that can persist for years, if not the rest of their life. There's a little bit higher risk of arthritic change in the knee with a BTB compared to the other grafts. But again, overall, the retear rates for this are very low. The hamstring graft is one where we take a hamstring. You can take one hamstring, you can take two hamstrings, and basically strip those off the inside back of the knee. This is usually through a smaller incision. We're not going to have the anterior knee pain that we get from the BTB graft. And that graft itself is actually stronger when we do failure testing than the BTB graft. Now, it is all soft tissue, and so the incorporation of the soft tissue into the tunnels is a little bit slower than with the BTB graft. We also see that grafts sometimes can be a little on the small side, and that can be a risk factor for failure. A third graft that's been more used in the past 10 years is the quadriceps. We take a strip of the quadriceps, which is the tendon that attaches above the kneecap. This is my preferred graft, and I use predominantly now because it allows us, we don't have the same anterior knee pain. It does result in a slight loss of quad strength initially, but offers the same retear rate and stability as the BTB graft without the anterior knee pain or donor site morbidity. With the allograft, one option is, we basically get a cadaver graft that's already pre-sutured and prepared to a specific length and diameter that we request. That offers then a much quicker procedure. So for somebody that may have a higher surgical risk due to the length of anesthesia, we're able to cut 10 to 15 minutes off the surgery time by doing an allograft in most cases. And that graft gets placed in the knee just like an autograft would. But then we're not sacrificing either a portion of the quad or hamstring or kneecap, so there's no donor site morbidity. So the main advantage with the allograft is patients wake up and these surgeries are not nearly as painful, and they can recover with much less pain. So for some patients that maybe aren't going back to real elite sports, their preference is to have less discomfort and easier rehab. And I think as long as they're able to follow the restrictions with the ACL rehab, they're still able to have a really excellent outcome, even with an allograft. So when we're determining which graft is correct, I kind of go over the risks and benefits with each patient, their family, and determine, what type of sports they're looking at doing. If for younger patients, there's a clear benefit to using autograft tissue. So I strongly discourage the use of an allograft in somebody under the age of 25. As we start getting into our mid-30s and later, I think the allograft's a reasonable option. Then a lot of it depends on what their preference is in terms of the risks or donor site morbidity with either taking a portion of the quad or the hamstring or the BTB. If we look at the main outcomes data through the MOON group, which is a multi-center study that's been done across the United States, we've shown that the retear rates and stability are equivalent with the quadriceps and the BTB grafts. There's a slightly higher rate of retearing with the hamstring graft, but most of the studies, it's not a significant difference. The majority of the ACL reconstructions can be done in an outpatient setting. It's a hour to an hour and a half surgery that's same day, so patients come in, are able to go home the same day. It lends itself well to an ASC or surgery center because we're able to then do the procedure at a much lower cost than it could be done in the hospital. They can be done in the hospital in certain indications. Sometimes we'll have patients with multiple ligaments injured. They may have a much longer surgery, multiple incisions, multiple grafts, a much more involved process where we need to monitor them afterwards. And those are reasonable cases in the surgery in a hospital, but for the majority of these we can do in an outpatient setting. The main thing I would advise patients as they're considering the ACL grafts and what to do for their own knee is to have a long discussion with their doctor about the risks and benefits of each one. What may be beneficial to one patient is going to be not the same priority to another. So it's important to kind of spell out what your desires are, what you see the post-op recovery looking like, what you're looking at doing 6 months after, a year after, 2 years after, because all of that may influence what graft we select. One way we are able to deliver low cost and high quality care for ACL reconstructions is by our ability to do these in our surgery centers. The outpatient surgery center offers a much lower cost option for this type of procedure. It can be done safely, it can be done well, and often at a 30 to 40% cost savings compared to more traditional avenues. We also have fellowship trained sports medicine surgeons that do high volumes of these reconstructions, and that offers the highest chance of quality and offers the highest chance of success for the patient, is making sure this surgery gets done right, gets done correctly. Preservation of meniscal tissue is important with ACL reconstruction, so those of us that are able to do other procedures at the same time and do them successfully is going to increase the chance of a successful ACL reconstruction.